When I was thinking about this devotional for the workshop, the section of scripture that I'm going to read came to me right away. In the story, we're provided with a glimpse of someone whose daily life and disease affected her life on a daily basis. It comes from the Gospel of Mark. The same story is in all three of the synoptic Gospels, but it's best illustrated in the Gospel of Mark. Jesus is surrounded by a large crowd, as he often is. Most of the time, the story is told with the focus. There's two miracles, and usually it's told with the focus on the little girl who's raised from the dead. And obviously, that's the most spectacular miracle in the story. But woven into that narrative is the story of a woman who has had continual bleeding for 12 years, probably her entire adult life, probably ever since she was about 12 years old when she became a woman. In the story, Jesus is approached by Jairus. Jairus was a ruler of a synagogue. And he falls at Jesus' feet and pleads with him to come save his 12-year-old daughter. The compassionate Savior that we have, Jesus, gets up right away and goes. But as he is leaving, a woman reaches out in desperation and touches his robe. If you don't have a Bible, I will just read the scripture. It comes from Mark, starts in 5:21. And it says, "When Jesus had again crossed over by the boat to the other side of the lake, a crowd gathered around him while he was by the lake. Then one of the synagogue leaders, named Jairus, came, and when he saw Jesus, he fell at his feet. He pleaded earnestly with him, 'My little daughter is dying. Please come and put your hands on her so that she will be healed and live.' So Jesus went. A large crowd followed and pressed around him, and a woman was there who had been subject to bleeding for 12 years. For 12 years, she had been bleeding. She had suffered a great deal under the care of many doctors and had spent all she had, yet instead of getting better, she grew worse." Oh, that sounds bad, doesn't it? When she heard about Jesus, she came up behind him in the crowd and touched his cloak, because she thought, "If I just touch his clothes, I will be healed." Immediately her bleeding stopped, and she felt in her body that she was freed from her suffering. At once Jesus realized the power had gone out from him. He turned around in the crowd and asked, "Who touched my clothes?" And of course the disciples answer, "You see the people crowding against you? How can we tell who touched you? Because there's so many people." So for 12 years, this woman has been suffering. And the text tells us that not only had she been suffering, but she had been suffering a great deal. She has been suffering for as long as the little girl whose father came to her to be raised from the dead. As long as she has been alive, she has been suffering. When Jesus realized the power had gone out from him, he stops and he looks for the woman. And because the crowd was so long or so large, he couldn't locate her. Now, if you are the father of this little girl, this 12-year-old girl, who's in danger of dying, and there's a woman here who is wanting Jesus' attention, and she's been bleeding for 12 years, wouldn't you think, she can wait a little bit longer? It's been 12 years. Come with me, Jesus. But Jesus doesn't do that. He stops. Now, in this culture, the man Jairus had standing. The woman did not. He was an important man, and the woman was an outcast. She's a woman, and in that culture, women didn't have much standing. Because of her bleeding, she was considered unclean. She would have been forced to live outside of her community. And like a leper, when she was approached, she would have to tell people that she was unclean. She would have found it difficult to earn a living. Who's going to hire you if you're considered unclean? Her condition would have prevented her from attending the feasts that were so important to the Jewish community. She would not be able to attend because she was unclean. She would have been prevented from interacting even with her own family. And we see in the text that she spent all of her money. She had to find a cure. You don't spend all of your money trying to find a cure on a trivial matter. Obviously, it was a grave matter. Her condition was overwhelming, all-consuming, and as the text even emphasizes, she suffered greatly under the care of many doctors. Now, I'm sure it wasn't one of the doctors that we have here today. Needless to say, it tells us that she suffered under many doctors, and instead of getting better, she got worse. Think about, with each doctor visit, the hope that she would have had that possibly this time I can be healed. Possibly this time they will find a cure. But time and time again, she went to that appointment only to be let down. Only to be told, no, you're not finding a cure this time. So she would go on to the next one, and the next one, and the next one, and spend even more money until she was out of money. To find a cure, she would be able to then get a job. She would be destitute, possibly get married, have children, interact with her family, to be part of a community of people. Can you imagine the shame that she carried with her every day? The rejection she would have felt? A crowd this size here, I'm sure there are some of you who understand shame quite well. I'm sure many of you can identify with her struggle of making a living and having strained relationships. The shame of feeling like something is wrong with you. And the diminishing hope with each misdiagnosis. The diminishing hope with each new medication that doesn't seem to work. I know I can identify with it. As far back as I can remember, even as a child, I struggled with anxiety and depression. Sometimes I just felt blue. But other times, I couldn't get out of bed. And it wasn't until I was in seminary when I became friends with a fellow student who was also a medical doctor, a psychiatrist. And eventually he began treating me. And after I started taking the medication, I woke up one day and realized I'm not depressed. And for about 3 months after that, every morning I would wake up, I would look over at my wife, and I would say, so this is what it feels like not to be depressed. It was life-changing. I know that I would not be here standing in front of you today if God had not put me in the company of that fellow student. That was a decades-long journey. And part of the reason it was so long, I believe, is because I was told by other well-meaning Christians that it's really any sort of mental disorder, any sort of mental health issue is really a spiritual issue, right? And that I shouldn't take medication for it. That maybe even God was punishing me. If you take nothing else from what I'm saying, just know that God is not punishing you, okay? You might need medication for the brain chemicals, for the chemicals in the brain. That's what I needed it for. It would also say that maybe I needed to pray more, or I needed to read Scripture more. Now, is reading Scripture good? Yeah. Is praying more good? Absolutely. But it's not going to solve your brain chemistry. We don't have a problem with taking medication for other issues, high blood pressure, chemotherapy. Pick an organ. right? We don't have a problem with taking those treatments to help the treatment for your liver or for your lungs or for your heart. But for some reason, when it comes to the fall, and the fall affected everything. The fall affected all of creation. It affected all of us. It affects our relationships. It affects how our body works. But for some reason, many people think that the fall only affects from the neck down. That if anything is up here, it's of a spiritual nature. No. Sometimes you need medication for the chemistry in your brain, for the chemicals in your brain. God is the source of everything good and everything true. And in His compassion, He has provided us with relief. Two ways of which are physicians and medication. Does He do it through other ways? Yes. Does He do it through prayer? Yes, by all means. Does reading our Bibles help us? Of course. Mental illness and death and disease was not part of the original plan. It was not part of God's original plan. This is not something that we were supposed to go through. This is not the way it was supposed to be. When Adam and Eve sinned, suffering entered the world. Now, why did this woman have to suffer for 12 years? I don't know. I don't have the knowledge and wisdom that God has. And I'm sure she wished that she didn't have to suffer, but suffering is part of living in this fallen world. But her story did not go to waste. God redeemed her suffering. We read in verse 32, but Jesus kept looking around to see who had done it. Then the woman, knowing what had happened to her, came and fell at his feet, and trembling with fear, told him the whole truth. He said to her, now listen to this, the word that he uses is very tender. He says, daughter, your faith has healed you. Go in peace. Go in peace and be freed from your suffering. Can you imagine the wave of relief that came over her at that moment, and the freedom that she now had from being healed by Jesus? It took courage for her to enter that crowd. I imagine she probably had a disguise, because people would have known her, and people would not have allowed her to come in, and because of her uncleanliness. So she wore a disguise. Jesus didn't have to call attention to her, but out of love and compassion, he did. She lived life in open shame every day to the world around her. And in front of everyone there, he declares that she has been healed. So there's no mistake. He tells everyone there, the big crowd, that she has been healed. And he holds her up as a model of faith. This woman who suffered much, who had no standing, who lived with the scorn of other people, is held up by God as a model of faith. Having as much faith as the esteemed synagogue leader Jairus. God valued her so much that he recorded her story in the Gospels. Billions of people read her story every day. The world looks on the outside, but God looks on what is on the inside. And he rewards those who seek him. When I get to heaven, I want to meet this woman. And I want to hear the rest of her story that wasn't written down for us. I imagine her ministry to people on the margin of society, and how she could bring the message of Christ's love, his compassion, his grace, and his sacrifice on the cross to those who need it, those whose journey she has been on. How she brought the same comfort that she received from God to others. I want to hear how God continued to redeem her suffering. I want to hear the rest of her story. I know for me, my story, as I have the opportunity to minister to other people, my suffering has made me a more caring person. It's made me a more compassionate person. It's someone who can relate to other people's pain. And God continues to use suffering to transform me, to transform my soul, to transform me more into the likeness of his Son, Jesus. Just as Jesus used her story, her pain, her brokenness, he also longs to use your story as well. Your story is still being written. Her story is a demonstration of faith in God's care and love and healing. She never gave up hope. She continued to seek God, and like her, he won't let your story go to waste either. Continue to believe that God wants the best for you, that the best is still ahead, and allow him to continue to write your story. Let me pray for us, and then we'll have the question and answer session. Jesus, thank you that you are a God who cares. You care about each person here. Jesus, I pray that you would speak into the deepest longings of their heart and meet them in their struggles, meet them in their pain, and bring them comfort and healing. Father, help us as a church to have wisdom, to have more wisdom as we partner with the medical community, to bring the care and the healing and the hope of Christ to a world that desperately needs it. And it's in your precious name that I pray. Amen. Okay, now it's time for the questions and answers. So, I'm scared.
That was low
Is
C.
that okay? Did that work? Okay. All right. So, have you guys passed out the cards to one another? Okay. All right. Well, Mike, thanks for going first.
Apparently I'm going first. So I didn't really organize my cards. I just kind of jotted a couple notes down on them as I went through, so in no particular order. PTSD, misdiagnosis, bipolar, and abused youth. I'm not sure exactly what this is referring to, but certainly that happens quite a bit. PTSD, for those of you who don't know, is a reaction to a trauma. Usually involves nightmares, flashbacks, but can create a great deal of mood lability. Especially if trauma was early on, or maybe even pre-verbally, so that there's not a great memory of it, that can affect your ability to control your arousal state. It's like, I tell people, it's kind of like the night before Christmas when you're really excited because you're going to get some presents tomorrow, and so you're kind of spazzing out. Eventually you go to sleep, your body kind of brings you back down. Or after work when you're kind of tired and you're like, oh, I want to sit in my favorite chair for a few minutes, I'm going to start dinner, and you know, that low, kind of pleasant sit in your chair arousal state. Again, comfortable for a few minutes, but after a couple hours, that may not be so comfortable. Just like if you're in a high arousal state after a couple hours, that may not be real pleasant. Well, people who have been traumatized, or such as some people have been traumatized, especially those with early trauma, tend to have dysfunction in their brain that inhibits their ability to kind of bring that arousal state back down to normal. And so, you know, it goes by various and sundry names, complex PTSD, a bunch of other things, but basically what it comes down to is you can't kind of get yourself feeling normal again. And so you tend to have kind of a whole bunch of dysfunctional behaviors that crop up around that to try and compensate for that, to bring your arousal state back. Some of which are healthy, some of which are not so healthy. Inappropriate sex, drugs, alcohol are some of the unhealthy ones. Exercise, meditation, those are some of the more healthy ones that again can kind of bring you up or bring you down in those kind of states where your ability to do that is impaired. So you can often get people with PTSD or misdiagnosis bipolar. You can also develop, if your behavior gets a little too, shall we say, rambunctious during a manic episode, you can actually give yourself PTSD through traumatic events during that time. So the interplay between bipolar and PTSD is not real simple, but they can look an awful lot alike, and one may in fact set you up for the other. Oftentimes there's an inciting event for bipolar as well, which may be in and of itself traumatic. So, so it's not a simple yes, no. It's a complex kind of interrelationship there, and it's certainly, we often will misdiagnose one for the other, and vice versa too, in an attempt to kind of move people forward. So yes, that happens quite a bit, especially in kids. Fair?
So, I don't know if this is something you experienced, but in the child literature, the past couple of years, the EPA, I'm hearing from people like Bob Post who are like, he's like the guru of bipolar disorder.
Or the mic.
So, a doctor, Bob Post, and a couple other old guys, older than me, which is really cool, are saying that because it seems like the U.S. has a lot more pediatric bipolar than any other place on the planet. And they're trying to find out why that is. And Bob Post felt that there were a couple of reasons. One is that more grandparents of kids with bipolar disorder have bipolar disorder. A lot of times they came from different countries to come here, to immigrate, and to cross the ocean and find big opportunities because they had a lot of ideas and a lot of energy to put forth those ideas and be successful in a new country. The other thing is that the United States apparently has the most trauma for kids. He was talking about like 3 to 4 times more bipolar kids early on. The problem is that these kids have not been diagnosed for over a decade, and so they stay untreated for a long time. And the trend is to try to identify them earlier and earlier because they know now that if you identify and treat early and aggressively, like Dr. Suzuki was saying, their lives are better. If you wait and you don't use the medication, you don't get the moods under control, you don't recognize the illness, then, especially when they have pediatric onset, when they're starting as a young kid, life can be really hard. So the hard thing about this is, and it's good that you all are here, that if you don't recognize that this is a severe mental illness and it's progressive and it's neurologic, you tend to be okay with what people will tell you, which is, oh, let's put more boundaries around the person, let's do more behavioral interventions, let's do neurocognitive training, let's do things that are maybe less researched and less effective than medications of severe bipolar disorder in kids. And so people are sometimes stuck in therapy or behavioral treatment or denial, saying this really isn't necessary to treat medically because you don't want to put your kids on the medicines. But the experts are saying if you delay and you let these symptoms go on, you really affect the course negatively for the rest of their lives. So that's the scary part. And the other scary part is the therapists that are a lot of times the first line, or the pastors or the church counselors are not treated or not trained enough to recognize these things, so they don't even know that the rambunctiousness or like the happiness of the kid you saw in the video is abnormal. they'll say, oh, what a sweet kid, what a funny kid, or what an energetic kid, what a smart, snappy, quick, humorous kid. Maybe he should go into comedy or something. But if you don't listen and you don't pay attention, you don't know that the kid is psychotic and that their thoughts are disturbed, and you know, it's not recognizing it and not treating it for what it is, and recognizing it's a severe illness can be very detrimental for the life course. If any of you had been at the depression meeting a few months ago, Dr. Wong at at CHOP was talking to me at some point, and CHOP opened up this great new pediatric unit, and they had beds, and they were going full speed, and they're doing a great service with a number of kid beds, but they did not expect to be this busy with so many young kids. They thought it was going to be adolescents, they thought it was going to be teenagers, older teens, but they are so surprised that there are so many young kids, like elementary school age. And we used to think that rarely, you'd see on training videos 3-year-olds with bipolar disorder, and it was like rare. It was like, oh, look at this. This is really unusual. But now it's not rare. It's like they're treating kids with lithium at age 3 in the hospital because they are so severe and so dangerous at age 3. So this is like, to be educated about this in any ministry position is really a good thing, because you never hear about it otherwise, unless you're in school or training or you have family who've been through this. That it's getting more and more common and more part of our culture. And when you get to junior high and high school, this is where you hear a lot of headlines coming up now. So it's great that church is doing this, and you are all here today.
So let me take a question here. How do you differentiate between everyday irritation with ups and downs and bipolar-driven mood swings? I think we all have normal ups and downs. That's a God-given emotional ups and downs that we have. But with bipolar manic episodes, again, it's a cluster of symptoms. It's not just one thing. And probably the most objective measure is sleep pattern. So, some of us spend too much money sometimes, we drive too fast, we talk too much. But sleep is one of those objective things. That being the case, many of us aren't always very objective about how we sleep. But often our patients take a sleep log. So for next month, when you wake up in the morning, actually mark down the calendar when you went to bed, when you woke up, and how many hours that is. And it's very hard to really have a manic type episode without having a pattern where your sleep is diminished. That's the objective. And again, as opposed to our sort of normal irritability and reactivity, which all of us are different with, some more than others, manic episodes or hypomanic episodes are episodes, they're episodic. So the question is, gee, John, if you've been more irritable, reactive in the last week or 2 weeks compared to what's normal for you. Right? And often it's very difficult for patients themselves to differentiate these things. So this is one of those illnesses where it's very important to have family members come in, a spouse or a friend or somebody, because a friend might notice that, gee, you've been more irritable last week, you seem to get into more fights with your friends, you get more angry when you're driving and yell at other drivers, you are spending more money. Because again, people in these episodes, like being a little drunk, people aren't often aware of how impaired their judgment is. But when you bring in the spouse, they say, oh, gee, you've really, the last few nights, been sleeping less, and gee, you're really irritated when you talk to the waitress at the restaurant the other day. So it being episodic and also that sort of different than what their normal behaviors are is what suggests it's an episode that could be a mood episode.
I only have to answer
Sometimes when I see teenagers, it's sometimes very hard to tell from the outside behavior, but adults and teenagers can sometimes tell you, it just happens. It's like, parents will bring them in and they'll say, normally I'm very responsible and very straight edge, very compulsive, and I care very much about following the rules. And then there are times where this just happens and I'm enraged, or I'm irritable and I'm screaming and yelling at my parents, and I don't know why it's coming out of my mouth. It's horrible. They feel guilty, they feel ashamed, they feel terrible, that they're terrible people. And afterwards, after the period is gone, they go, why did I do that? There's no reason why I should be treating people like that. And they feel, if it happens long enough and they don't know what's happening, they start to think that it's just me, I'm a bad person. That really must be part of me. But when they tell me in a session that, I feel really terrible, and the parent says, I used to be a sweet little kid, and all of a sudden they've turned, for a few hours, they're a monster. And then they're guilty, they apologize. And so then it's an episode in the game identified as, okay, easier to spot until it becomes part of their identity. And then they start to believe they're bad. It's sad. How do you differentiate, or no, how do you motivate a 20-year-old who suffers from bipolar or cyclothymia? And is lamotrigine available in injection form today? Second question is easy, no. There is no injection of lamotrigine, although there is in development in the next year or two a liquid form. So it's not an injection, but liquids are these are pills sometimes. How do you motivate a 20-year-old who suffers from bipolar disorder? That is a kind of a tough one. It's kind of a therapy question. How do you find out what the patterns are for the kid? How do you ally with the kid? How do you kind of try to encourage them either to get counseling or to hold them out of bed in the morning and go for a walk with them, kind of like what you do with adults who are depressed, or help them with information, take them to a NAMI meeting, take them to a DBSA meeting, and help them see that this is not necessarily that they have to live with this the rest of their life this way. There's something they can do. But if they become more oppositional, how do you motivate a 20-year-old anyway? That's kind of a big question. But when it's bipolar, you try to get them when they're really shifting and they're making a mistake, and then you help them identify this may not be what they do some help for.
I'm also a big fan in that, and several of the questions that come up kind of reflect this, is in terms of how do you help someone get help? How do you motivate someone into treatment? And this is something that that is a struggle, especially in the late teens, 20s, when your identity is kind of separating from your parents and figuring out who you are as an adult outside the context of your parents. You don't want to be dependent on mom and dad anymore. And so I will tell you my general strategy is first to pause. It's easy to kind of say you need to, but to pause and to enter into their pain with them, to join them in their life and be a co-journeyer with them. Job's friends didn't get into trouble until they opened their mouth. When he was sitting on the ash heap for 7 days with them, the Bible didn't have anything bad to say about them until they started talking. So silence rarely gets you into trouble. That's a good take-home message. But I think entering into people's pain with them, identifying with them, sharing parts of your own pain with them that kind of help you connect, and then talking about how their pain is and their behavior and their decisions are causing increasing problems for them. There's a whole pattern of psychotherapy around that called motivational interviewing. Read some books about it if you want. But in terms of entering into their life and then kind of looking from their perspective on their problematic behavior, how it's impacting their life and causing more problems for them, and then kind of doing a cost-benefit analysis. Hey, it doesn't seem like things are going well here. Do we want to try and do something about this? I'm here to support you, but you're 28. I can't make you do anything anymore. You know, when you were 4, I could, you know, threaten to ground you. Can't really ground you anymore. You know, if you're into corporal punishment, I can spank you. I'm not going to spank you, 29-year-old man. You know, so the point is to kind of enter into their lives and then just have. I'm a big fan of, you know, kind of living their life with them and saying, you know, maybe now isn't the time, but maybe we know that you're seen to be doing a lot of damage, and let's see if we can help you make some better decisions, help you make some better choices so that aren't going to be damaging to yourself and to the people around you. I'm worried, but but I am also not in control anymore. You are, and so acknowledging that shift and co-journeying with them and helping them understand, not telling them, but asking them questions to kind of bring out how their behavior impacts their life and how it damages their life, often is helpful. But oftentimes, I think I said in there, it seems in my world about 3 times before people are willing to figure out that their mania costs more than it's worth. About 3 hospitalizations or about three go-rounds before they figure it out. Some people are figure it out earlier. Some people they never do figure it out. But on average, I'd say about 3. And just co-journey with them and help them bear the pain and help them, you know, and then ask them, hey, what are we going to do about this? You know, and figure it in their own life.
Yeah, the other thing I think about is, now again, this is a very genetic disorder, these. So oftentimes either the parent or the grandparent or whoever in the family has also suffered from depression or other mood disorders. So I always tell my parents who have kids, make sure you let your kids know that, you know, I suffer from depression, I suffer from anxiety. There's nothing wrong with going to see a psychiatrist, taking medication, getting therapy. So again, destigmatizing it. I read an article a few days ago which was very interesting about our use of language and mental illness and how early and how ingrained we stigmatize it. I went over Disney movies and how there's so many Disney movies that show mental illness, you know, like in Beauty and the Beast, you know, the father gets locked up and taken away to the mental asylum. But from a very young age, we are stigmatizing our kids. There's something wrong. We're talking about feelings that are bad or that there's something wrong with you. So I think the more that we can be open about our own struggles that we go through in life and our need to get help, I think that helps our loved ones be more accepting of help.
Did you have one?
So the question that I was given, if you're familiar with the story of King Saul, do you believe his behavior may have been a result of bipolar with psychosis? I don't know. But we do know, and maybe one of the doctors here can talk about psychosis and if there's a psychotic break there, and when you're an animal, you think you're an animal, if there's a certain diagnosis for that. I'm pretty sure it's not mad cow disease, but that might be an option. So let's just talk about the fall of it. And I addressed this in my remarks, but this is not, the world that we live in now is not what it's supposed to be like. Right? So our bodies, our creation is subject to disease and death, and sometimes that disease affects our minds. And so we need treatment, we need medication. So I don't believe they had medication for bipolar back then. They probably didn't know that it was bipolar with psychosis. Can either of you address whether or not it was bipolar with psychosis? And what do you think?
I don't remember the episode you were talking about in regards to him being an animal. Kind of what jumps out at me is kind of his reactions with David playing the harp when he's chucking spears at him randomly, which is not real good for relationship building. Some of his wandering away from what God had to say. I don't know as I would have necessarily called that psychotic behavior. Maybe a bit antisocial, maybe a little, what might be along the lines there. There was certainly a fair amount of insecurity that went on, especially after he was rejected by God. I don't know as I would have to spend some more time thinking about it. I never thought of Saul as a potential bipolar, so I'd probably want to read through it again. I'm not sure I can identify much of the way bipolar spectrum stuff, but apparently Dr. Akamoto may disagree with me.
So it's the part where he was kind of feeling like he was a cow and eating grass.
Saul? That wasn't
So all of these figures in the Bible who are going through suicidal thoughts or psychotic kinds of things or grandiosity, from our position as psychiatrists, it's a little bit of a jump to sort of do diagnosis. We're not supposed to do that because, one, it's a different time and it's a different age and different ways of reporting symptoms. But it's always interesting because we have people through history and through Christianity. Some people thought maybe Paul had some bipolar characteristics. Or Martin Luther is another figure who had a lot of psychiatric issues, and it was their mood dysregulation for him. But it's part of life. It's like people looked possessed; they were psychotic looking. So was there possession? That's a whole another week conference on spiritual possession. But when we talk about stigma and trying to see how the Bible applies to our spiritual lives and how does it incorporate us, how does it incorporate our pain, how does it incorporate our fallenness, it's totally consistent with healing and what God provides for us in terms of reconciliation and healing. I was looking for a way to include this verse, which is, that's right there. So 61:2, Isaiah, which is the Beauty for Ashes passage. To preach the acceptable year of the Lord and the day of vengeance of our God, to comfort all that mourn, to appoint unto them that mourn in Zion, and to give unto them beauty for ashes, the oil of joy for mourning, and the garment of gladness for the spirit of heaviness. So, when we read passages like that of comfort, it's like, well, all my patients who are going through depressions or mixed states or agitation and the hellishness of something like bipolar disorder, it's like what Jim was talking about. The Bible speaks to it and speaks to our comfort through the scriptures and through prayer and through the healing that we receive through our spirituality and our relationship with God. So it's going to be there all through history. But it doesn't mean that we can't be, like Dan saying, having normal lives or having victorious lives. And people who are very impactful had bipolar disorder. I think we know, even though we're not supposed to diagnose, we know factually that Churchill had bipolar disorder, that Roosevelt's had bipolar disorder, Martin Luther King, and maybe Lincoln, sounds like it's likely. So very major people in the history of society and the world, the free world, have done wonderful, amazing, life-changing, world-changing things for good. So yeah, it's in the Bible, and whether Saul was bipolar, I don't know if that's even relevant. But there are, this is a part of our lives here.
Okay.
Another question here. There's actually, isn't it the Goldwater rule after Barry Goldwater that Actually, by ethics and psychiatry, we're not supposed to comment on diagnoses of political figures or other people since we're not going to Okay. Well, we'll have to come up with a term for Bible figures. So the question is, the Suzuki rule. Apart from taking medications, what other daily routines can help a person with bipolar remain stable? So again, sleep is critical for two reasons. As I said before, number one, it's a very good marker and indicator if you're on the manic side or depressive side. So if you start sleeping 10, 12, 14 hours a day, then gee, you should talk to a doc. Maybe you're depressed. If you're sleeping 7, 6, 5 hours a day, well, maybe you're getting manic and you should talk to a doc about med adjustment. So it's a marker of how your mood is, but equally important, it also can trigger episodes. So again, like working with college students, it's finals week, they go for a week and they're staying up all night studying, or you're doing some type of project at your work and staying up late at night. If you have a tendency towards manic or bipolar disorder, that certainly can trigger mania. So I am very, I educate patients very clear on the fact to monitor your sleep. It's one of those very boring things to do. Who wants to get up and put on the calendar how many hours they sleep every night? But it's really that objective thing. People, there's a lot of spending too much money and talking too fast. Some of that gets a little bit subjective. But if you can monitor your sleep on a regular basis, that's very objective. So it's an indicator of having a mood swing, but also can help prevent mood swings. So that's an important structuring thing. And again, there are triggers that cause episodes to happen. There's a phenomena that we call kindling. So if you get a rat and you put an electrode in the brain, and I've never done this, so I'll peanut people, but if you put an electrode in a rat's brain and you put voltage in that, you hit a voltage where it causes the rat's brain to seize. Right? After you do that for a period of time, it takes less voltage to cause the seizure to happen. And after a while, the brain starts seizing in the rat spontaneously. Right? We think it's sort of a similar concept with bipolar disorder. The more episodes you have, the more fragile the brain becomes. And just like an electrode, either internal stressors, psychological issues you have to deal with, traumas, or external stressors, you get divorced, you go bankrupt, bad things are happening, all those can trigger episodes. So basically, healthy living, dealing in therapy with issues you have to deal with from the past or current issues, all those things at a level of emotional stability in one's life will decrease episode and provide structure for the person.
All right. What is the unique treatment modality for pediatrics versus bipolar disorder regarding balance of population? What are exacerbating variables? How can this be addressed at the primary and secondary levels? So I'm not sure what you mean by the primary or secondary levels, so I'll disregard that unless you want to give me some clarification. There's several ways that pediatric bipolar disorder is different from regular bipolar disorder. From a neurologic standpoint, there's different areas of the brain that are involved. There's hypoactivity in the frontal cortex. There's hyperactivity in the amygdala, which you don't see as much in the adult bipolar patient. There's Dr. Suzuki could probably give you all kinds of crazy stuff about brain functionality in the adult bipolar. But there's also differences in terms of how they present. A child with bipolar is much more likely to present in a mixed state than an adult is. They're much more likely to present with more irritability rather than elevated mood, than an adult is, which makes it a lot harder to kind of pick up, and why mixed states and kind of milder states are harder to pick up in kiddos. Additionally, in terms of treatment, there's several treatments, several specific psychotherapies that are designed for pediatric bipolar disorder. Their names are actually in my handout if you want to dig them out. There's additionally differences that I didn't go into in here because I didn't think you would care. In terms of the medications that we use, like for adults, you will often use Depakote, Tegretol, Lamictal, lithium. Depakote, the anticonvulsant mood stabilizers like Depakote, Tegretol, and Lamictal are not nearly as effective in children as they are in adults. Our first-line agents are almost always, I refer to them as the second, third generation antipsychotics rather than the atypicals, but are those kind of antipsychotic medications which seem to be a lot more effective. They also tend to be more treatment refractory. You're much more likely to get control, you're much less likely, I should say, to get control with just one medication. Often you have to use 2 or 3 medications. Comorbidity, with the exception of substance use, is more common in kiddos than in adults. So they're also less verbal and more controlled by external factors, so you can't get the really graphic displays very often. Because parents are and teachers are exhibiting some controls on their behavior, so oftentimes you have additional sources where you can pull from, but you don't always get the extremes. Kids are not always the best reporters of their sleep. I had my son, who does not have bipolar disorder, but told me he slept 2 hours on Thursday night. Well, I know that's not true. I checked on him more than that, and he was asleep every time I checked on him. And he slept for more than 2 hours before I went to bed. They're not always the best reporters in terms of how much they're sleeping and how, So things get a lot more complicated with a kiddo than with an adult, just because the kiddos are more complicated, I think, in general, and we don't know them as well as we know adults. All the work is in adults because the adults have the money, and so although the work that gets done in pediatrics is almost always right before a drug's about to go generic. They will get, if they can get a pediatric indication, they will get another year on kind of trademarked so that no one can make generics of them. And so we get, right before something's about to go generic, we get a bunch of research on it that have to do with kids. So so we're always 5-6 steps behind the adults in terms of the studies and the research that's going on. And there's a lot fewer child psychiatrists than there are adult psychiatrists as well. But those are some of the differences between there and in terms of treatment as well as presentation. Does anyone want to tell me what the primary and secondary levels are? Or shall we? You can always email me as well if you want to. Maybe primary versus secondary school? Maybe? So obviously the closer you get to adulthood, the more likely it's going to look like more of an adult typical presentation than with a kiddo. As you get older, the prime first episodes are still in the 20s for guys and the 30s for gals. I'm overgeneralizing to make the point. There's specific ranges. But as Dr. Okamoto mentioned, we're seeing more and more commonly these kids getting picked up for for a variety of reasons, changes in diagnostic criteria being one of them, trauma being another one that we're becoming more and more aware of trauma as well, and then immigration issues. We're seeing a lot more of it in college students as well, as the kids, I think in part because kids in last generation wouldn't have been able to get to college because of their struggles, are now able to kind of get to college and be successful in college because of the supports that come along with them. So I think that's a good part, frankly. But I don't know, anything you guys want to add? Okay.
Yeah, one thing to echo what you said, which also comes up too practically with patients, is this question about taking different medications, multiple medications. So another study a few years ago is that the average person with a bipolar illness is taking 3 medications, right? But that's not inconsistent with these days people say on diabetic medication or blood pressure medications. There are multiple mechanisms in the body used to treat certain illnesses. So it's not a bad thing to need to take 3 different medications, right? On the surface it sounds bad, but it could be that there are different mechanisms that control your blood pressure or your blood sugar or your moods. And it's not a bad thing to take 3 different medications that are working mechanistically in different ways in the brain. So people often get hung up on that. Question here is, what is the typical ratio of depression, manic, and normal behaviors? So, a simple answer is there's no specific pattern. It's very, very variable. And it's based on the genetics, the type probably of bipolar variant you have, as well as the life stressors you're going under, whether or not you have other comorbidities, whether you're taking recreational drugs. So again, in the old days, before we we're giving people medication and such, the typical pattern was manic depressive. That's what we call a classical pattern. And if you have a classic pattern like that, it was thought that lithium was more effective in treating sort of that classic bipolar depression. But these days with mixed states and these various different patterns people have, then most people don't often have a classic pattern. But if they're untreated by a classic manic depressant, we often think about lithium. The other thing is, up until about 10 years ago, the last studies I was looking at, the unfortunate reality is that most patients, there's the mania, there's the depression, and there's the euthymia. Most patients who have bipolar illness were living below the line. They're more or less chronically depressed. Again, those are the studies at least 10 years ago. We do have more medications these days for specifically bipolar depression that aren't antidepressant medications. So there are certain atypical second, third generation atypical antipsychotics which are mood stabilizers specifically for bipolar depression. They don't flip people into mania. So hopefully that's a little bit better. I haven't seen the most recent data. But unfortunately, oftentimes people live under the curve. And that's where, if that happens, you want to load on more mood stabilizers rather than antidepressant medications, because that can make them worse. And then the question is on the same person, if you go off meds and things get worse and worse, do things get better and better if you go back on the meds? I would think of it sort of like smoking. Best not to smoke at all, and the longer you smoke, the worse it gets. But that being the case, better to quit as soon as you can. So same thing with the bipolar illness. If people go off medications, and people frequently do, like people are saying, they may take multiple episodes or multiple education before they understand and stay on it. Even if they have, the sooner people can get back on meds, stay stable, not have episodes, the better for the long-term prognosis.
How can I better deal with family and friends who are bipolar and disruptive? So that's a little difficult because that mixes in, well, how do you deal with conflicts? Part of the answer to that is the two tables in the back, the DBSA and NAMI. They have ongoing meetings of support groups and networking, and NAMI has training for relationship issues. How do you take care of your kids? How do you take care of spouses? How do you deal with bipolar symptoms in the family, and what kinds of things can you do? What's nice about it is that you can share experiences with other people and families who've gone through this and deal with this kind of the same things. It's kind of amazing to hear that what you thought was your own specific, unique situation, lots of families go through that unique, specific situation, dealing with bipolar symptoms or bipolar family members. And it's not easy, it's not intuitive, and it's easy to do the wrong thing. And there's not necessarily a single answer for a single situation. So it's kind of managing the bigger problem, which is how do you know when to intervene and when not to intervene, and how much. So those are things that take a while to figure out and learn. I think Mike talked about certain types of therapies for different kinds of bipolar symptoms in kids. Nowadays there are certain psychotherapies for people with bipolar disorder, and one of them is family-focused therapy. So that's within the family. There are ways to learn how to identify patterns and how to support the person who has bipolar disorder. And it's kind of talks about sleep cycles, talks about the cycles of the mood changes through the year, and how the family members can encourage and identify those changes to help the person go through it. So there are specific psychotherapies that address those kinds of problems, but support networks, and kind of part of what we want to do here and other churches is how do we get churches to be able to be part of that support. So kind of like when people go through chemotherapy or they go through cancer symptoms, how do we come alongside and support the families, and support individuals going through this with their spouse or their kids. So it's kind of, I hate this phrase, but it sort of takes a village. You kind of know that one, but it's more. It takes the church. It takes fellowship. It takes a communion of the saints to kind of help each other with our burdens. And so hopefully we can get better at that.
And just to add one more thing, and we have a couple here, but the church has many resources, many ministries, one of which is Stephen Ministries. And they're not counselors, they're not therapists, but it is a way for the church to come alongside people and bear those burdens as we're told to do. And so they will meet with you once a week and just hear you, just listen to you. You know, oftentimes we don't have somebody who will listen to us, who we can tell our story to. So they will sit with you, have coffee with you, pray with you, read scripture if you want, but mainly they will listen to you and walk through life with you. So if that's of interest, we also have cancer and grief and a lot of things on our website. But if that's of interest to you, grab me, grab Peggy, and we'd be glad to talk to you more about it.
Yeah, you know, the Bible said that comes to mind with that too is, you know, the story of Lazarus and how, Martha, the sister, comes to Jesus and lets him know that Lazarus is dead, and it's been 4 days. And you know, that shortest scripture that we all memorize probably when we were a kid, John 11:35, Jesus wept, right? And the thing that was always striking to me is, I mean, Jesus knew that he was going to go see Lazarus and raise him from the dead. And he could have reassured Martha and Mary and let them know that everything's going to be okay. But the first thing he did is he wept with them. And I think that compassion that he showed and just being there with them, I think is often what our people, our loved ones need when they're suffering, be it mental illness or physical illness. So that was all striking to me. Question here is, can you tell me more about bipolar 2 and cyclothymia? I really think this may fit my husband, but it seems fairly off the radar in the medical community, at least at Kaiser. So how is it ruled in or out so we know what to ask for? Yeah, so you saw the symptoms of mania, and probably if somebody walked up here and they were in a full-blown manic episode, what you know now, and most of you could recognize that pretty clearly. But bipolar type 2 is where you have major depressive episodes, but instead of having a full-blown mania, you have a hypomania. So one way to practically think about hypomania is as the same type of symptomatology: brain's going too fast, on the go, talking too much, being distractible, but it's to the degree where it doesn't cause too much functional impairment in the way we classically think about it. So, I would love to be hypomanic all the time. That would be good. Get more done, get less sleep, be more social, creative, everything. But the problem is, it's very hard to live on that edge. So if you're hypomanic, there's a good chance you're going to go way up or go down. But bipolar type 2 is where you have that major depression and hypomania. That's where there's certain medications, say for example Mictal, that's not as strong as some of the others. So you're full-blown manic, Mictal won't necessarily cover that. But if you're hypomanic, it may cover that, will help the depression. And cyclothymia is where, again, you have hypomanias. Rather than having a full-blown major depressive episode, it doesn't meet full criteria. So the amplitude is different. So again, treatment can be a little bit different in terms of medication management as well as therapy to get those mood swings under better amplitude control. And the question about what do you do with a healthcare provider, I think in bipolar illness, as much as probably any other psychiatric illness, it's incredibly important to have spouses, family, be able to give information to the doctor, because oftentimes the patient themselves is unaware. It hasn't caused that much severe dysfunction that they're aware of it. And by law, a doc cannot give you any information or even acknowledge that we've seen a patient unless the patient's given written permission. However, that doesn't exclude a loved one to call on the doctor and say, I know you're treating my husband, you may not have permission to speak to me, but let me tell you what I've been observing. Right? So we appreciate the information we get, even though we may not even be able to call back or acknowledge that we see that person. So again, in bipolar illness, there's a lot of lack of awareness among the patients, so collateral information is very important. And if you've seen a doc and it seems like they're not getting it, the more information you give them, that would be helpful, I think.
I think that at the end they asked about something about pediatric cyclothymia and bipolar type 2. Yeah, they clearly exist in kids. There is much less research done on them. I don't know of any treatment studies with cyclothymia in the pediatric population that has been done. And it's obviously a hard diagnosis to make. The more extreme the symptoms, the easier it is for the physician, right? So if you are extremely manic, okay, that's an easy pickup. If you're kind of just right over the line, that's a lot harder in terms of picking up. And that gets magnified when you are talking about a kid who may have already a baseline high energy level or comorbid ADHD or something like that to kind of magnify that. So it's really hard to get a good study population together to actually study these things. But we do know they exist. I've seen them, so I can assure you that they do. Right now, in lack of better information, we kind of treat them in many ways the same way that we treat the adults in that population or other pediatric bipolar disorders that we, again, have more information and clearer treatment guidelines on in terms of the medications and the psychotherapy. So hopefully that answered the question. Okay. Shall I read one of mine, or do you want to read one of yours? Okay. That's basically, we talked about that already. Okay, well, I can't read that one. What does it say?
So the question is, what do you think about using CBD hemp oil? Well, that's a tough question. So we can probably tell you what we think. The problem is there's very little studies that have been done evidence-based at this point related to marijuana and CBD specifically. And since it was against the law for so long, studies weren't being done. So, THC, CBD, there has been approval for certain medical illnesses, but not any psychiatric illnesses at this point. And, marijuana has dozens and dozens of cannabinoids in there, and we have cannabinoid receptors in our brain. So all the major universities, UCLA, are beginning to have multi-million-dollar grants looking into this. But at this point, we really just don't know. At least that would be my opinion on it. And I can just tell you, at my psychiatric hospital, we are dealing on a daily basis, people coming in where marijuana is quite decompensating their moods. So there's tremendous need for caution now with that at this point.
I'm not aware of any kind of really good studies looking at it. There's some case reports. Of course, if you talk to the guy in the marijuana shop, he's going to tell you how great it is for bipolar disorder. I have had a couple of families who tried it with their younger kids and found it to be spectacularly unsuccessful. Almost all of my teenagers, it might be a slight exaggeration, but certainly a lot of them will try to use it to help them sleep at some point or another. I've not seen it work in full-blown mania, and it probably is disrupting sleep architecture and making their sleep much less efficient. And so I generally tell people, it's pretty clear that in some cases it destabilizes mood. There's not any evidence to show that it's efficacious, and it may be causing you a problem. So while we're trying to get things under control here, I would advise sobriety. And if you can't have sobriety for any length of time, that also tells us something about your kind of dependence on this substance, and maybe we need to look at some kind of rehab situation. And then once things are stable, if you want to, this is legal in our society right now. If you want to experiment with it, okay, fine. But I would say while we're trying to stabilize you, it's not a good idea, and it may not be a good idea down the road either. But that's a bridge that I'd say cross that bridge when you're actually stable, not now when you're in my office and we're trying to stabilize you.
So, I had some contact recently with the guy doing the trials at UCLA. I can't remember his name right off the bat, but there's a lot of studies on marijuana in general, especially young kids, being really bad.
Yes.
Right?
Yes.
So, not specifically CBD.
Younger, worse.
Yeah. So, deterioration of IQ points, motivation, high risk of schizophrenia developing. I've had a number of kids who get psychotic, they go to the hospital, they go out, they smoke again, and then they get back in the hospital. So their lives are kind of stuck and going downhill. So for kids, and the person who's doing the UCLA stuff, he says, he's a Chinese guy, and he says, I told my kids, if I catch any one of you getting into the pot, that, well, for sake of political correctness, he said, I will take the prerogative of a parent, and you will be severely punished.
I have a feeling that was sanitized.
Yeah, really, yeah. If you know Chinese culture, it's kind of harsh. So, but he was said before the age of 25, no, at all. There's not really good studies on CBD, and there are, you know, if you're going to take it for terminal cancer or severe epilepsy, and there's nothing else that works, I don't have a problem with that. But that's not what they're promoting it for. They're promoting it for kids and for everybody, for everything. So we're not happy with it. We don't have safety studies, and it'll be a while before we have it.
I think there are some legit uses for it. I've used it in the past for air hunger when I was doing consult liaisons. If you're on a vent and you're conscious and you're fighting to breathe over the vent, it works really well. Used it in pill form for that. But in terms of mental health stuff, I'm not aware of any positive data, except for, like I said, from the guy in the head shop who's trying to sell you this stuff. I'm not aware of any positive data beyond a couple of people saying, oh, it was helpful. So I advise against it. So.
Well, we are out of time, and it seemed like it went quickly, didn't it? Would you please help me thank the doctors one more time? We as a church are committed to raising the awareness of mental health issues in the church and the community, and I'm so glad that you are here. If you need a place for somebody to walk alongside you in community in our church, I would encourage you to come. Come check us out some weekend and join us. The other thing is we have about 3 more calendared already for these types of workshops. The next one will be in September, and it is on ADHD. Yes, thank you. So sign up for that. I know it said this time you don't have to sign up. Next time, sign up, please. That really helps just for planning. So thank you for coming. Let me give a blessing to everyone before we leave, okay? May the Lord bless you and keep you. May He make His face to shine upon you. God bless everyone. And if you have questions for the people on the panel, doctors on the panel, come on up.